Now, what are the clinical features of a pre-eclampsia patient? So these patients can come with increase in BP, which is a most common and the first presentation. It occurs due to vasoconstriction, and timings of increase in BP may differ. So in pre-eclampsia patient, usually the BP is increased after 20 weeks of gestation. In most cases, after 34 weeks of gestation, and and around 10% patients presents with preterm preeclampsia, that is BP elevated before 34 weeks of gestation, while 5% patients may present as postpartum preeclampsia, that is BP is increased after 48 hours of delivery, and molar pregnancy in APLA patients can present even at 20 less than 20 weeks of gestation. Recurrence risk of preeclampsia is if the BP is increased more after 34 weeks of gestation, then there is recurrence rate of 6%, while in case of preterm preeclampsia the recurrence rate is 25% in next pregnancy. Patient can also present with pathological edema, and it is seen in all dependent and non-dependent areas. We can do grading of edema also. If the edema is present just below the ankle, then it is grade 1, and it is if it is between ankle and the knee, then this is grade 2 edema. If above knee edema is present, this is grade 3, and if anasarca, that is generalized edema, is present, then it is characterized as grade 4. Now we have to differentiate between physiological edema and pathological edema also. Physiological edema is seen in dependent parts of the body, and it disappears after rest, while pathological edema can be seen in both dependent as well as non-dependent parts. It can be seen in the vulva of the patient, on face, and it can also present as anasarca. Now, due to this pathological edema, there is weight gain in the mother. There is sudden increase in weight gain, that is more than 1 kilogram weight is increased in a week, and it does not disappear after rest. So the first feature is raised BP, second feature is edema, third feature is renal involvement. Renal involvement is the first and the most common organ system which is involved, and this can cause decrease in GFR, which is a glomerular filtration rate reduced. Now if GFR is reduced, there is increased in serum uric acid and serum creatinine level. Normally in pregnancy we consider a serum creatinine of less than 0.9 as normal, because in pregnancy there is increased renal blood flow. But in preeclampsia patient, because renal blood flow due to vasoconstriction is reduced, and hence GFR, that is glomerular filtration rate, is reduced. So if the serum creatinine is even more than 1.1 milligram per deciliter, is considered as abnormal. Patient can also present with oligouria, which is abnormal urine output, that is urine output less than 100 ml in 4 hours. Hypocalciuria due to increased tubular reabsorption. Calcium is also increased in urine, decreased in urine, and increased serum uric acid due to decreased GFR and increased tubular reabsorption. Now on histopathological examination, we can look on renal biopsy, and we can see glomeruloendotheliosis, which is a characteristic histopathological feature of preeclampsia, in which there is swelling of endothelial cells of renal capillaries, blockage of capillary fenestration, glomeruli are enlarged by 20% and typically bloodless. Homogeneous subendothelial deposits can also be seen, which are made up of protein and fibrin-like material. Patient can present as acute kidney injury, which is seen in 5% cases of preeclampsia and 15% cases of HELLP syndrome. AKI is associated with increased risk of HELLP syndrome, abruptio placenta, and postpartum hemorrhage. Generally, milder forms of kidney injury seen. If AKI occurs due to acute tubular necrosis with comorbid hemorrhage, then patient can present with hypovolemia and hypotension also. Now the most common system is involved is renal involvement, and more common involvement is also seen with hepatic involvement in patients with severe preeclampsia. The physiological features associated with liver involvement are increased in ALT and AST levels, but rarely more than 500 international unit. Hepatic enzymes like ALT, AST are raised, and they are corresponding inversely to the platelet counts. Means the platelet count is reduced while the liver enzymes are elevated. Enzymes may return to normal by 3 days after delivery. Anatomical features means on histopathological examination, areas of ischemia and hepatic infarction can be seen. There can be periportal hemorrhage that can lead to hepatic hematoma, epigastric pain, right upper quadrant pain increased in ALT and AST. Now, what is the differentiating feature between HELP syndrome from acute fatty liver? So, in acute fatty liver of pregnancy, enzymes are also raised. So, how will we differentiate between these two conditions? The amount of tissue involved may be extensive but clinically insignificant in HELP syndrome, and HELP syndrome rarely leads to liver failure unless it is caused by obstetric hemorrhage like shock liver, and there is no evidence of pancreatic involvement. So while in acute fatty liver tissue involvement is more, there are chances of liver failure, and pancreatic involvement is also seen. There is one thing known as a hepatic hematoma, in which blood is collected within the liver, and patient can present with epigastric pain, nausea and vomiting. It occurs due to stretching of the liver capsule and indicates severe preeclampsia or an impending eclampsia. Management is conservative, that we have to control the BP, and if the liver rupture is there, that is hepatic hematoma is ruptured, then surgical interventions are necessary. Patient can also present with cerebrovascular involvement, means that is brain involvement that occurs due to cerebral vasospasm, and there is impaired cerebrovascular autoregulation leading to leaking of fluid and causing cerebral edema. This occurs due to endothelial cell injury. The manifestation is PRES. PRES is posterior reversible encephalopathy syndrome, and it is an MRI finding occurring due to cerebral vasospasm, impaired cerebrovascular autoregulation due to vasogenic edema, and it mainly involves the occipital cortex and the parietal cortex. Patient can present with headache, visual disturbances, mainly scotomas, abnormal excessive neuron activation leading to seizures or eclampsia, and blindness. Now, headache can also occur. This is one feature PRES. Headache can also occur, and this headache is throbbing type, not usually relieved by the medications. Patient describes this headache as the worst headache of life and can involve any region. Earlier it involves occipital region also, but in preeclampsia it can involve any region, and it is a sign of impending eclampsia. The more severe presentation of preeclampsia in cerebrovascular system is a stroke, which occurs due to severe, that is cerebrovascular accident. Patient can also present with visual disturbances like scotoma, blurring of vision, diplopia, and these symptoms usually improve with administration of magnesium sulfate and BP control. Blindness can also occur in preeclampsia, and it is seen in 15% cases of eclampsia. It can be seen a week after delivery also. It is reversible. It arises from the occipital lobe, mainly the visual cortex, and hence known as occipital blindness, also known as amaurosis fugax. It occurs due to cerebral edema, usually lasts for 4 to 8 days, but it resolves in almost all cases. And this blindness can also occur due to lateral geniculate nuclei and the retina, and if it is occurring due to retina, it is known as a retinal blindness. It could be due to retinal ischemia, retinal infarction known as Putschner's retinopathy, and retinal detachment. Retinal detachment is usually unilateral, may lead to total visual loss, and may be asymptomatic, and in most commonly in cases it can improve after delivery. In all cases of severe preeclampsia, fundal examination hence should be advised to the patients. If blindness is due to RAO, that is retinal artery occlusion, it can result in permanent visual loss, and preeclampsia patient may also develop abruptio placenta presenting as bleeding per vaginum. Now, what are the signs of impending eclampsia? Patient can present with headache and dizziness, epigastric pain, nausea and vomiting, maybe due to hepatic hematoma, visual disturbances, and sudden onset of dyspnea and orthopnea due to pulmonary edema. Now, what lab investigation would you like to do in such patient? First one is CBC. We have to check the hemoglobin level, because the hemoglobin level might be increased, hematocrit might be increased, because the blood is getting lost into the intracellular space, and platelet count is reduced. So hemoglobin is increased, hematocrit is also increased, and platelet count is reduced. Hemoglobin is increased because of hemolysis, Peripheral smear can detect hemolysis by showing the signs like helmet cells, schistocytes, and the Burr cells. LFT is advised. LFT is advised because liver enzymes are elevated both in severe preeclampsia as well as HELLP syndrome, and they are usually more than twice the normal value, but rarely exceeds more than 500 international unit. In liver function test, we also see serum bilirubin levels. Total bilirubin is elevated, and mainly the indirect bilirubin is increased due to hemolysis associated with HELLP syndrome. We would also like to do a coagulation profile. LDH levels which are elevated, coagulation profile might be deranged, and serum haptoglobin levels which are reduced in preeclampsia, and it is only done if LFT is deranged. KFT can also be advised. KFT will show serum uric acid elevated, serum creatinine raised, 24-hour urinary protein excretion, serum calcium levels which are reduced in such patients, and urine routine microscopy for chronic kidney disease can also be done. Fundal examination is also advised. It is usually done once to check the baseline levels and to look for hypertensive retinopathy, where we use Keith Wagner's and classification. There is no role of ECG in X-ray in such patient. Now, what is the frequency of testing in gestational hypertension patient? We will do it once a week for GTN, gestational hypertension, non-severe preeclampsia twice weekly, and in patients with severe preeclampsia we will do it on alternate days, while if patient with severe features with conservative management, or if there is patient with HELLP syndrome, then we will do her lab investigations daily. So in gestational hypertension, once a week; in non-severe preeclampsia, twice a week; in severe preeclampsia, thrice a week; and daily for HELLP patient.